Good afternoon, everybody. Welcome to the Women's Health and Fertility Podcast. Today's guest is someone so many patients search for after years of unanswered questions and being told that their pain is normal. Dr. Sadikah Behbehani is a nationally recognized OB-GYN and one of the leading endometriosis specialists in Los Angeles and Newport Beach. She is uniquely trained with double fellowship expertise in reproductive endocrinology and infertility, as well as minimally invasive and robotic gynecologic surgery, a combination held by only a handful of physicians in the country. Dr. Behbehani specializes in Dr. Behbehani specializes in treating complex conditions like endometriosis and uterine fibroids, particularly when they affect fertility and quality of life. As an experienced excision surgeon and pelvic pain specialist, her work centers not just on treating disease, but on truly listening to patients and helping them feel heard, validated, and hopeful again. In today's conversation, we're diving into endometriosis, pelvic pain, fertility, surgical options, and what patients should really know when navigating these diagnoses. I am so excited to welcome Dr. Sadikah Behbehani. I am so excited to welcome Dr. Sadikah Behbehani to the Women's Health and Fertility Podcast. Thank you so much for being here. Hello, everyone, and welcome to the Women's Health and Fertility Podcast. Today's guest is someone so many patients search for after years of unanswered questions and being told that their pain is normal. Dr. Sadikah Behbehani is a nationally recognized OB-GYN and one of the leading endometriosis specialists in Los Angeles and Newport Beach. She is uniquely trained with double fellowship expertise in reproductive endocrinology and infertility, as well as minimally invasive and robotic gynecologic surgery, a combination held by only a handful of physicians in the country. Dr. Behbehani specializes in treating complex conditions like endometriosis and uterine fibroids, particularly when they affect fertility and quality of life. As an experienced excision surgeon and pelvic pain specialist, her work centers not just on treating disease, but on truly listening to patients and helping them feel heard, validated, and hopeful again. In today's conversation, we're diving into endometriosis, pelvic pain, fertility, surgical options, and what patients should really know when navigating these diagnoses. I'm so excited to welcome Dr. Sadikah Behbehani to the Women's Health and Fertility Podcast. Well, hello, Dr. Behbehani. Thank you so much for joining me today for the Women's Health and Fertility Podcast. Let's see, we met just a couple months ago, and I had heard about you through several mutual patients, and they both raved, or all of them raved about your care and about your expertise on endometriosis. And I have to say, in the last 20 plus years that I've been practicing, many of my patients are diagnosed with endometriosis a little bit later than I think that they would hope for, especially after they've gone through several cycles of IVF and then not having any success, and then coming back to realize after further investigation that they do have endometriosis. So this topic is really near and dear to my heart to be able to help patients really, really dig a little deeper to find out the true cause of some of their health issues. So I'm thrilled to have you on today. But first, I wanted to start off by asking you a little bit about your journey into medicine and what led you to specialize in obstetrics, gynecology, and reproductive medicine.
Thank you, Dr. Yang. First of all, thank you for having me on this podcast. Fertility and health, those two terms together to me always equals endometriosis because I can't tell you how oftentimes people think it only affects fertility or it only affects their health and not really has any fertility impact. So
Mm,
being on a podcast discussing fertility and health and talking about endometriosis, I think is the perfect setup. So I appreciate you setting this up for us. And then
yes,
also,
thank
I
you.
love working with you because Endometriosis care is multidisciplinary.
Hmm.
I can't do it on my own. We all have to help each other. And
Right,
this kind of
exactly.
brings me to the reason why I specialized in this field is because we are all women here. We completely understand the struggles, the unique struggles that women face when it comes to fertility, the unique struggles they face when they feel like their bodies are not doing what they're supposed to be doing. And so we need to support each other. We need to help women better understand what's going on with their body and help them fix the things that they may not really be focusing on because they're little pieces to the puzzle that we need to work on in order to get the big picture for them to feel healthier and for them to be able to get pregnant. And this is why I did what I did with my training. So I'm a little
Hmm.
bit of a unique situation because I went to school for a lot longer than most OB-GYNs. So
Hmm.
I did medical school and then I did OB-GYN training. And after OB-GYN training, I decided I wanted to help women get pregnant because it was such a wonderful experience being part of the fertility world, being in a fertility office, you're retrieving those eggs, creating embryos, helping couples conceive. It was just a very joyful environment to be around and very rewarding because science has come such a long way and it's beautiful to see how we are now able to use science to help those couples start families. And, it's not always a traditional path to fertility. Women can't always just get pregnant naturally, but it's
Sure.
okay because we have the science and the advancement in technology to help them get pregnant. So I love the field of REI, which is reproductive endocrinology and fertility. But there was a big missing piece because some of these women were not getting pregnant with IVF. They
Hmm.
had other issues. They had fibroids, they had endometriosis, and they needed surgery. But as reproductive endocrinologists, as a fertility specialist, we get trained in surgery very minimally. It's a
Hmm.
small part of our training. So, training is 3 years typically. So, a small part is dedicated to surgery. The rest is dedicated to IVF, hormones, fertility treatments, research. We don't really learn how to operate as much. And so, we had to send those patients out to surgeons to do their
Sure.
fibroid removal and
Hmm.
endometriosis excision. But then they weren't getting the right fertility care with their surgery. They'd come back to us and now they've lost half their ovary, their uterus is scarred, it's hard to get
Right.
pregnant. So
Hmm.
I decided I wanted to be that surgeon that can help my reproductive women improve their chances of fertility without damaging their organs. So I did a second fellowship training in minimally invasive GYN surgery. And did I know that I was going to be specifically an endometriosis specialist at that time? No. But I knew I was going to go into a field that few people wanted to go into because of the additional years of training. At some point, we
Sure.
want to stop and start
Right.
practicing. But I'm so glad I did it. If I go back in time, I would 100% do this journey over and over again because now I'm one of the few people who are surgically trained to tackle advanced pelvic disease and fertility trained to understand the details and the science behind conception and pregnancy and the very delicate organs that we work with in fertility. So then endometriosis happened to be my specialty because it's the biggest disease that encompasses both. It requires surgical treatment and requires fertility care.
Right.
And so
Right.
here I am today on your podcast talking about endometriosis, which is near and dear to my heart. I practice at the Center for Endometriosis and Fertility because this is what my passion is, and this is what my practice is geared to, is to help women with endometriosis either get pregnant or help women with endometriosis preserve their fertility, restore their organs so that when they're ready to get pregnant, their body is cooperating and they're hopefully able to conceive naturally and skip fertility treatment.
Sure. That's amazing. And I love how you bridged the two, the three things together actually, and knowing that I want to go deeper into my training to be able to serve my patients and comprehensively be able to help these patients conceive, prepare, for their journey into parenthood. So that's incredible. Well, let's back up a little bit. For someone that is not that familiar with endometriosis, would you be able to give like a brief explanation of what it is and how it's typically diagnosed?
Yes. So endometriosis basically refers to when the lining of the uterus or cells that are similar to the lining of the uterus travel outside the uterus. They could be found on the bladder, they could be found on the bowel, they could be found on the ovaries. They're very unique and special tissue. They're not really exactly like the lining. They have different characteristics. They have different receptors. Those tissues or implants actually produce their own estrogen. They create
Mm,
scarring. So think of that uterus functioning every month, shedding the lining, women get a period. Those implants or deposits are like little blueberries scattered around the pelvis, and the bleeding that happens every month in those implants has nowhere to go. Unlike the
right.
uterus, which sheds the lining,
Hmm.
woman would bleed into those implants. It would create scarring and it would create pain. And the biggest question I always get asked is, why do I have endo? Where did it come from?
Sure.
Most women are born with those cells. It's nothing they did
Mm-hmm.
wrong. It's not their diet, their lifestyle, or their preferences that created the deposits to grow. They've always been there. However, those cells were undifferentiated cells. They were nothing. And then with stimulation, with ovulation, with periods, those
Hmm.
cells became uterine lining cells.
Right.
So for some
Okay.
women, their pain and their symptoms start with their very first period. And for other women, they were fine for the first 10, 15, 20 years before they started having pain because
Hmm.
those endo implants grow and develop differently in different women. For some women, they can be active and they could be very painful right away. And for other women, it could take a while for those implants to become active and become painful.
Hmm.
And when we're talking about the diagnosis of endometriosis, we mostly base it on women's symptoms. So I hear you when you come to my office and you say, Doctor, I don't feel like myself. Something's going on. I'm constantly hurting. I always feel tired. I always feel sore. I feel like sometimes not myself. I can't think. I have brain fog that's bothering me. I have constant chronic fatigue that's bothering me.
Hmm.
And even though they may be coming to see me for fertility, they're trying to get pregnant, I can't ignore those symptoms because those symptoms are affecting patients' quality of life. So then I start asking the endometriosis questions. So tell me more. How is your pain? When did your pain start? When did your periods become painful? And then as we direct our focus on endometriosis, patients are dying to know, well, tell me, do I have it? How do we diagnose it? I cannot tell you whether or not you have endo just based on listening to your symptoms. I highly suspect it. That's what I think you have. I tell them I have a 90% chance or 99% suspicion for endo. But the only way to prove you actually have endo or not is to do surgery. So
Hmm.
what we do with laparoscopy or minimally invasive surgeries, we go in with a camera, we look around the pelvis, and when we find those implants, those little blueberries that shouldn't be there, we cut them out. And that's the best and only way we can get rid of endometriosis. The reason why you and I work together a lot is because that's not the end of the story.
Sure.
Endometriosis creates a lot of inflammation. It creates a lot of stress on the muscles, on the nerves, on the just general health and well-being of a person. So even after we remove all the disease, we still need to undo the years of pain and inflammation and
Hmm.
soreness that have developed over the years. So endometriosis is inflammatory, it's multifactorial. It affects multiple organs and requires a multidisciplinary team to treat. I'm the surgeon. I'm one big piece of the puzzle, but I'm not the entire puzzle when it comes to
Hmm.
pelvic pain. And that is why I always tell patients they need to listen to their bodies and they need to tell me what's still going on. So if after surgery they're still having pelvic floor muscle tightness, they're still having fatigue, they're still having brain fog, then I need to send them to the different specialists to work on the other pain generators or the other inflammatory disorders that might have developed in conjunction with endo or because of the endo.
So let me ask, as far as the care that you provide, and it sounds like there's integration with other providers. Who are some of the other specialists that you work with to treat these
Great
patients?
question. Yes. So first of all, endometriosis oftentimes affects other organs, not just the reproductive organs. So I'm happy to help with endosurgery. I'm happy to help with egg freezing. I'm happy to help with IVF and fertility. But I don't want to ignore the other symptoms. So if women are still complaining of bowel symptoms,
Hmm.
so bloating, diarrhea, constipation, those are common symptoms with endo. Let's say we surgically remove the endo and they still have some bowel symptoms. We need to undo all the inflammation of the bowel that has developed over time. I send them to a GI doctor, a GI specialist that can test the motility of the bowel. They can check how the bowel's moving. Are the nerves super irritated? Is there SIBO, small intestinal bacterial overgrowth? Is there a shift in the flora of the gut? Do we need to treat that with antibiotics or anti-inflammatory medication? Some women have bladder symptoms, frequency, urgency, pain when you
Hmm.
urinate. Then I send them to a urologist, a female bladder doctor, to talk about whether or not they have interstitial cystitis, if they need something called bladder hydrodistension or installations of the bladder. I work very, very closely with pelvic floor physical therapists because
Hmm.
all my patients who have pelvic pain oftentimes also have muscle spasms in the pelvis from the years of pain that they've been going through with their endometriosis. So then I have them work with physical therapists to relax those pelvic floor muscles. And then I always have them work with acupuncturists. And acupuncture works on two things. It works on fertility because there's strong data to say or support the use of acupuncture when women are trying to get pregnant. So I
Hmm.
love for my IVF patients to do acupuncture during IVF and during their embryo transfers. And you probably know more about this than most people do. And then the second thing acupuncture can help with is pain resolution too, because remember, the nerves are hypersensitive. Gentle touch that to other women may not create issue, to those pelvic pain patients may become painful. They get
Sure.
diagnosed with fibromyalgia. They get diagnosed
Hmm.
with chronic pain disorders.
Right,
So
right.
acupuncture can help calm down those sensory responses so that they're not as stimulated and they're not as painful anymore.
Thank you so much for that really comprehensive definition of endometriosis, because I think it's such a complex condition, and so many facets of it is ignored. And I have treated many patients over the years that have had undiagnosed endometriosis, but they've had other diagnoses such as chronic fatigue, fibromyalgia, and infertility. And it's really, I don't want to say mysterious, but it's because it is a condition that is diagnosed through surgery. I think a lot of patients are avoiding the surgery, or maybe they're afraid of it. So for those patients, how would you be able to sort of ease them into this thought or this idea that it may be a good option for them to consider?
First of all, I have to say that endometriosis is very poorly understood. And if someone is not there to look for endo and ask questions about endo, they don't want to know if someone has endo because they don't know what to do with it. So for all the
Mm-hmm.
fertility doctors who are in IVF offices, it's easy for them to schedule you in for an IVF cycle because they know what they're doing with IVF. They know
Sure,
how to get your eggs and create embryos. But when you start asking questions as to, but doctor, why did I not get pregnant? Oh, you have unexplained infertility. We don't really know why, but you know what? It
sure.
doesn't matter. Let's move on and get you pregnant. But endometriosis is the commonest cause of unexplained infertility. A lot of those women, if we just take our time and ask them questions, we would realize that they check off all the boxes, they have all the symptoms of endometriosis. They have pain with intercourse, they have bloating, they have severe pain with their periods, they have bowel symptoms, they have bladder symptoms.
Hmm.
And we can't ignore them because endometriosis actually decreases your chances of pregnancy with IVF. So even if we said, let's just forget about your pain, let's just make embryos and then put the baby
Sure.
back in the uterus, with an embryo transfer, success chances are reduced in the presence of inflammation and
Hmm.
endometriosis. So we
Definitely.
can't ignore endo. So if your doctor doesn't bring it up, you should think about it and you should bring it up. And actually, I would say 90% of my patients are self-referred because they
Hmm.
did their research. Their doctors didn't tell them you could have endo, go see an endo
Sure.
specialist. They went
Right.
online, they asked ChatGPT, they asked their friends, who've gotten pregnant, hey, can you tell me more? What was your journey like? Word of mouth. Women are talking to each other. Women are on social media now gathering information, which is sad because we would love for doctors to be the ones providing accurate
Right.
information.
Right.
But because
Absolutely.
endometriosis is so poorly understood, a lot of doctors don't have enough knowledge about it. Remember, I told you I had to do extra training to become a surgeon and an endometriosis specialist because they don't teach you that in OB-GYN residency. You get limited teaching on endometriosis and fertility. All the IVF doctors know endometriosis is bad for your fertility. Everybody knows
Mhm.
that. But then what do we do about it? The fertility doctors don't operate. They don't know how to surgically treat it. So women get put on Lupron sometimes. So if they have an
Right.
unsuccessful embryo transfer, they get told, well, it could be endo. Let's put you on Lupron. And if Lupron doesn't work out, then okay, now you need to consider surgery. But in my
Hmm.
opinion, first of all, we are not helping the woman feel better by giving her Lupron because Lupron makes you feel miserable. You go into
Hmm.
menopause. We're putting a band-aid on the problem just for that embryo to stick. But then what? They have the baby and we're back to square one. And all
Right.
the endometriosis is back and all the symptoms are back. And number three, this woman is not going to be the best version of herself taking care of the baby because she's going to be in pain. She's going to be in bed on her period. She's not going to want to do stuff because she's tired and she has that brain fog and the fatigue. So I always tell my patients, we need to do things in the right order. I need to help you
Right.
feel better first. You need to
Hmm.
feel better about yourself. We need to treat the actual cause of infertility. So if it was unexplained and we suspect endometriosis, just like we would treat male factor infertility, just like we would treat anovulation, we need to treat your endometriosis. Get rid of it. And then guess what? 50% of those patients who have surgery for endometriosis get pregnant naturally. And those are
That's
women with
amazing.
infertility. Can you believe it? Those are women with infertility. 50% of them will get pregnant naturally. And then if you look at IVF chances, the chances of implantation are significantly higher with IVF once the endo is all gone. So if we compare the
Hmm.
same population of women who've gone through IVF, embryo transfers, not pregnant, we do excision of endometriosis, their pregnancy chances with IVF are now significantly elevated and significantly improved. So I don't see a reason why women should put their bodies through IVF first if we have a strong suspicion for endometriosis. And I know surgery sounds invasive, but it's laparoscopy. Nobody gives you the choice when you have an inflamed appendix, right? They say your appendix
Hmm.
needs to come out. Women go
Sure.
through surgery to have an appendectomy. Your gallbladder, when you have gallstones, you get told your gallbladder is inflamed, it has stones in it, needs to come out. We go through laparoscopy. Same with excision of endo. It's the same procedure, same recovery, same day discharge, 2 hour surgery, but it gives us so much answers and it gets rid of a chronic disease that's creating inflammation in the pelvis. Is surgery the answer for everyone? No, it has to be a discussion between you and your doctor. There are
Hmm.
pros and cons to every treatment option. With surgery, a lot of physicians or REI doctors, fertility doctors are worried about ovarian reserve. Remember, I
Yes.
told you in training, when we send our patients to surgery, they come back with half an ovary,
Hmm.
scarred uterus. All those issues happen with surgery. So you need to make sure you're having surgery, first of all, with a specialist who knows what they're doing, someone who's really careful around the fertility organs. And then, despite all of that, even in the best of hands, the ovarian reserve or number of eggs on the ovaries may drop after surgery if we are doing cyst removals on the ovary. If
Hmm.
we're not touching the ovaries, there are no cysts on the ovaries, then it's not going to change your ovarian reserve. Time alone will drop your ovarian reserve. But if the ovaries are scarred, they have disease on them, they have big cysts on them, then that's when we need to weigh the risks and benefits and come up with an individualized treatment plan. Not all my
Right.
patients get surgery right away. Some need to
Hmm.
freeze their eggs before surgery. Some
Sure.
create embryos, and when they're happy with the number of embryos they have, then we do IVF.
Can I
I
ask
mean,
you a
surgery.
question? I'm sorry to interrupt for 1 second. I'm just thinking about, with the inflammatory aspects of endometriosis, I'm wondering too how much it can impact your egg retrieval cycles too and the quality of your
Exactly.
embryos.
That's an
And
excellent question.
hmm
Just yesterday, I saw a patient in the office who had 22 eggs retrieved from IVF, and she thought, excellent, I'm set. I'm going to have all the babies I want to
sure.
have. None of those eggs made it to blastocyst. No
Ah,
embryos to transfer at all. They all stopped growing because she had such poor quality eggs. And she had endometriomas. And her doctor knew she had endometriomas, but said,
mhm.
let's try and do IVF and see what happens.
Right.
But now the egg quality is so poor, they
Hmm.
still offered her another IVF cycle and said, let's try again. But she came to see me for a second opinion. And I said, hold on. You've tried it once already. It didn't work out. The eggs were terrible. What is going to change if we do it again one more time? Have we changed anything in your medical history? Have we changed anything in your pelvis? Have we done any interventions? No, we haven't. So we're going to expect very similar results second
Sure.
time around too, unless we do
Right.
something drastically different. And so
Hmm.
we talked about surgery to remove her endometriomas, but I told her, you're not going to get 22 eggs next time. You're going
Hmm.
to get less than 22 eggs. But I would rather have 10 good eggs that I can work with and make babies from than 22 eggs that arrest and nothing happens.
For sure.
We don't have strong data to say that excision of endometriosis help improve egg egg health or quality of the eggs. There's not very data on that, very limited because those
Hmm.
studies are still fairly new and it's very challenging when it comes to egg quality to kind of give it a scale. But we have good data that excision of endometriosis helps improve pregnancies with IVF. And for me,
Hmm.
that's enough because
Hmm.
that's our end goal. I don't want to see eggs. I don't want to see embryos. I want to see pregnancy numbers.
That's right. Yeah.
That's what the couple wants. When they come to see me, they want to take home a baby at the end of the day
Hmm.
and not just say, success, we got eggs or success, we made embryos. We want pregnancy. And excision of endometriosis helps improve both natural pregnancies and IVF pregnancies.
So, if a patient decides they want to go through this surgery, how much time do you usually recommend the patients to wait before they start trying, either naturally or with some type of ART?
With most excision of endometriosis surgeries that don't involve uterine work, because again, the uterus is a separate issue with fibroids or adenomyosis. So
Hmm.
when we don't touch the uterus, just the pelvis, remove all the endometriosis, they can try naturally 2 weeks after surgery. So I usually see them for a 2 week post-op follow-up. They're back to normal activities. They're feeling great. They can resume sexual activity and they can try and get pregnant naturally.
Hmm.
If we are doing IVF, I tell them to wait a little longer. I say, let's wait 6 weeks because I want all the inflammation to go away. I want their bodies to be back to 100% normal because it takes a lot of money, a lot of effort mentally and physically to go through IVF.
Absolutely.
And I
Yes.
want to make sure we set them up for success. So I say, let's wait a full 6 weeks before egg retrieval. Some of those patients have had embryos stored already. So that
Hmm.
6 weeks after surgery, we work on transferring the embryo. The only delay with surgery and pregnancy comes with fibroids. When we remove fibroids that are deep into the muscle layer of the uterus and we suture the muscle layer of the uterus, we need to give the uterus a good 3 months to heal before
Okay.
we get women pregnant.
Which
But
I know for
otherwise,
a lot
just
of patients, they're just like, that seems like forever,
I
right?
know,
3 months.
exactly.
Hmm.
But you know what? Time flies by. I would rather have a controlled 3 months than say, okay, keep trying, and then they come back 6 months later and they're not pregnant. Now
That's
we have
right.
to do everything.
Then they've
But
lost more time. Yeah.
fibroids
Hmm.
are the only situation that really we need to wait. But
Hmm.
excision of endo, and actually the highest pregnancy chances reported are the first 6 months after excision of endometriosis. So
Hmm.
I always encourage my
Interesting.
patients who are interested to try right away. Don't
Hmm.
wait because the highest pregnancy chances are the first 6 months. Because think about it, that was the reason for infertility. Something was dampening the chances, something was suppressing your chances. Now it's gone. And the egg and the sperm can finally do what they're supposed to do
That's
and meet and
right.
fertilize. Yeah.
Yes, exactly. So if a patient ends up with the surgery, they will hopefully have a successful pregnancy and a healthy baby. And let's say they decide, okay, I'm going to wait a couple years before I try for baby number two. And this is a question that I get a lot. Is there a risk and a chance that the endometriosis will come back?
Grow back. Good
Grow.
question, Dr.
Hmm.
Yang. Yes, I get asked this question every day. Endo does not grow back that quickly. It's endo that wasn't appropriately removed the first time that
Hmm.
continues to be a problem or flares up after a while. So if you get a good excision surgery and you remove every spot of endometriosis you see, including the microscopic deposits, which I know sounds crazy, but this is what we do with the peritoneal stripping. So the type of surgery I do, I remove wide margins around the spots so that we strip the entire pelvic covering. The chance of endometriosis coming back is less than 20%.
Amazing.
It's about 10%. Most of patients who come see me for their third or fourth or fifth surgery and they say, oh, I'm used to it. Endo comes back every year. It's not that. It's that it wasn't appropriately treated or removed. You just remove one or two spots, you leave everything behind, or you ablate it, you burn it. Ablation, they just burn
Hmm.
the tip of the iceberg and say, that's the best we can do. That's all we can do. If someone tells you your endometriosis is unresectable, it means they cannot remove it. They don't have the skills or technique to remove it. There is no
Okay.
disease that's unresectable. It just means it needs more skill and sometimes a multi-collaborative approach. I have bowel doctors I work with. I have bladder doctors I work with because sometimes we have to be aggressive and cut a chunk of the bowel out or cut a chunk of the bladder out to get rid of the disease. But those
Hmm.
patients usually have so much symptoms. They have so much bloating, so much pain with bowel movements. They have bloody stools with their periods. They need to have that surgery. And so to tell them it's unresectable and expect them to just live like that, I think is unfair. And I have many patients who come see me after they've tried extensively to get pregnant. They're now in their late 30s, early 40s, and say, Doctor, I am done. Just help me. Just get rid of my uterus. And it
Hmm.
makes me sad because if I'd met them
Yes.
10 years ago, I might have been able to help them actually get pregnant, but by the time
Hmm.
they see me at 39 and 40 and 42, their ovarian reserve kept going down and down,
Hmm.
nothing was working, and it's because their endo has been there for a long time. So they finally
Hmm.
get relief when their hysterectomy is done. But doing a hysterectomy doesn't treat your endometriosis. You can't just expect to have a hysterectomy and then not have any disease anymore. So I operate on women who've had hysterectomies all the time to remove residual
Mm-hmm.
endometriosis that was not excised the first place. I actually just did one today, this morning. I was in the OR this morning, and this poor lady had surgery for not endometriosis, had surgery for pelvic pain 2 months ago. So the doctor knew she had pelvic pain and then wanted to do a hysterectomy, went in and saw endo everywhere and was not equipped to manage the endo. So they called the bowel doctor, they called the bladder doctor, they tried their best, they finally got the uterus out, and in their eyes, the surgery was successful because they completed the hysterectomy. But the
Mm-hmm.
patient continued to have pain after surgery because they weren't really able to remove all the endometriosis. They actually looked at her appendix and they said, your appendix looks weird. There's something wrong with it, but we can't remove it. You need to have
Mm-hmm.
another surgery. She went to see a surgeon who said, you want me to remove your appendix for pain? That's not what I do. I only remove an appendix if it's ruptured or inflamed. You need to see a pain doctor. It's probably all in your head.
Oh,
So,
yes. That is something
right?
that they're told, my patients are told a lot.
Right, exactly.
Mm-hmm.
I know. It makes me mad because this patient, this poor lady, has come to you asking you for help, and she has pictures with her to say that her appendix looks weird. We don't know what it is,
Mm-hmm.
but it looks unusual. And he says, no, no, that's not it. The pain is in your head. So she comes to me, a gynecologist, and asks me, can you remove my appendix? And I said, absolutely. Not only your appendix, I need to see what's going on in there, why you're still having pain. And we found lots of disease and scarring and fibrosis and
Mm,
adhesions
yes.
and removed the appendix as well. But I'm just saying, everyone presents differently. Having a hysterectomy does not cure your endometriosis. If someone just removes the uterus, leaves all the disease behind, guess what? It's still going to be there when you
Mm-hmm.
go back in 2 months later, or 2 years later, or 6 years later. So you want to have one good surgery. You want to clear up all the endometriosis. If women are trying to get pregnant, we save the uterus. If they're not trying to get pregnant, it's their choice if they want to have a hysterectomy. A hysterectomy is not a cure for endo. The cure is, and there's no cure, it's a chronic disease, but the best treatment plan is to remove every single spot of endometriosis you see so that this woman has the best chance of resolution of her pain and never needing to come back into the OR again.
That is ideal. And it sounds to me like outside of fertility, you're also helping patients with endometriosis that maybe are are no longer in that phase of life where they can have children, or maybe they have unfortunately given up
Yeah,
on
absolutely.
that.
I don't just manage fertility patients. I see a lot of older women who are done having
Hmm.
children. I see women who are not ready to have children. I operate on teens. I have 14-year-old,
Mm. Oh,
17-year-old patients, unfortunately. And those patients are here because guess what? Their moms had similar symptoms.
sure.
Yeah, right. The 14-year-old girl,
Hmm.
her mom had terrible periods until she finally was diagnosed by a surgeon and had treatment of her endo at the age of 40. So she said, I don't want that for my daughter. I don't want her suffering through 30 years of pain. So she came to
Yes.
see me at 14, had all the symptoms of endo. We did her surgery, had lots of endo. We removed the endo. She has an excellent chance of having better quality of life. And we reset the clock for her so that
That's
hopefully
amazing.
all that disease she was, born with or was there since birth is now gone. And
Hmm.
hopefully, for her, for being 14, she probably will need another surgery at some point in her life because she has another 36 years of periods. But is it going to be the same surgery as if we'd ignored all the endo and left it there for 36 years? No. Doing laparoscopy multiple times is unnecessary. You need to treat it all at once and then see what happens. But sometimes it is needed if the endo
Hmm.
comes back. But if it comes back, it's going to come back in different spots than where you removed. And it's still going to be
Right.
early stage disease because you didn't give
Sure.
it enough time to fester and grow in there.
So it sounds to me like there's definitely a genetic component to
Yeah.
endometriosis.
There's a huge genetic component, but it doesn't mean you have to have family history of pelvic pain or endometriosis. Some patients come see me and no one else in their family has ever had painful periods. But most come see me and say, my mom told me it's normal because that's how her periods were
Sure.
when she was my
Right.
age, right?
Right. Right.
And my sister had the exact same thing growing up, and then she had kids and she's better now. So my mom's just telling me to wait until I meet someone, have children, and then I'll feel better. But that's not really fair. It's not fair
Hmm.
to expect women to get pregnant just to treat their pelvic pain. It is not right either because not everybody who gets pregnant will have resolution of their pain. Some women still continue to have pain after surgery, sorry, after pregnancy.
Hmm.
And then also, what are we going to do with this baby when the baby comes if the couple are not ready to have children? If we're telling those girls to just get pregnant so they feel better,
Sure. That's
you
that's
know, that's
that's not
really
that's not necessarily the right solution.
absolutely not ideal. Yeah. So pregnancy does not cure endometriosis, but back to your genetic component question, yes, there is a family history component to endometriosis. Although, something I've recently had a set of twins, patients, identical twins. One has endo symptoms, one doesn't have endo symptoms,
Hmm,
but they come from the same exact genetic material. So,
that's
and their mother
interesting.
had pelvic pain and endometriosis, so they probably both have the tendency to develop endo. One has symptoms from it, one doesn't. So not it doesn't mean that you absolutely have to have endometriosis if your mom had it or if you have family history of it.
Well, let's talk about lifestyle.
Okay.
Lifestyle, diet, like what are there things that can be done to prevent or to mitigate or, just help to minimize symptoms of endometriosis and some of the inflammatory responses and the pain and discomfort that patients go through?
Yeah, absolutely. Because, like we said, the endo does irritate and trigger a lot of inflammation. So, an anti-inflammatory diet, for example, can help with the symptoms, but it's not going to cure the disease. Because sometimes women come and say, well, doctor, I'm doing everything. I'm working out, I'm eating healthy, I'm still in pain. It's not going to
Mhm.
make your disease go away, but it can help with the symptoms of the disease.
Sure.
Same with acupuncture for pelvic
Mhm.
pain. It can help calm down all your nerves, it can help you feel better, but it's not going to make the endo regress or go away. So, the healthy diet, exercise, anti-inflammatory diet, acupuncture, meditation, all of those interventions, a very new one recently, GLP-1s, right? Those reduce inflammation too. Very common.
Mhm.
I see it in a lot of my endo patients. They are on GLP-1s to lose weight, but they feel great. Their pain is gone.
Sure.
So it does help decrease inflammation. Very new, not currently approved or recommended for treatment of pelvic pain or
Well, okay, so let me
endometriosis.
ask you this question. If a patient comes in and they are on GLPs, but they want to get pregnant, what is your recommendation as far as how long they should be off of it before they start trying?
Honestly, I tell them not to stop until they
Really?
are. I don't, because I'll tell you, we don't have data. We don't know. The guidelines say 2 to 3 months. That's just arbitrary. That's just, people coming up with a safe number to say, okay, if she's
Sure.
been off it this long, then it's safe.
Right,
But
right.
if she's on it and she's feeling great and she's losing weight and she's finally having periods and she's finally ovulating, I don't want to mess that up for her. I don't have any data to say that being on it is dangerous to your baby. There's
Hmm.
zero data to say that being on it is dangerous to a pregnancy. It's just all theoretical and possibilities because we don't have data. So I tell them you can stay on it while you're trying, but not while you're doing IVF, because while you're doing IVF, we for sure know we're going to collect this egg in 2 weeks. So just give me 2 weeks off it. But I don't have them stop it 2 to 3 months before. I
Hmm.
have them stop it when they're doing IVF, right at the start of the cycle. If we're doing surgery, they need to stop it a week before surgery. That's just anesthesia recommendations. If we're trying naturally, I tell them it's fine to stay on it, but as soon as they're pregnant, they can come off it.
Okay.
If we're
Makes
doing an
sense.
embryo transfer, I tell them to stop it while we're prepping for an embryo
Hmm.
transfer.
Hmm.
That's just my personal recommendation based on all of us being scientists and just thinking of the pros and cons and what's better for our patients. I would
Sure.
rather have my patients feeling great, continuing to lose weight, than have a possible theoretical, you know, risk. And I counsel them on it. I tell them, this is what I think, this is the data, you decide. Some are very, very worried and concerned, and rightfully so. They can stop
Hmm.
2 to 3 months before trying to get
Sure.
pregnant.
Yeah, I
And
think
some say,
they,
please, some beg me, please, doctor, don't make me stop. And I say, sure, then stay on it. But you understand the risks. We don't know.
yes, that's fair. And I think it is really important to have patients kind of come to their own conclusion and their comfort because there is not enough data there yet. And like you said, when patients see themselves losing weight, feeling better, less pain, less inflammation, they don't want to stop because they
Yes.
feel
And
so
I'm not
much
going to be the
better.
bad man that makes them do it.
Right? You don't want to be the bad guy that says, okay, you have to stop it, and now we're going to start all these other medications, right? So is there anything else that you would like to share with listeners in terms of like fertility or anything about endometriosis if a patient is
I have a
thinking,
take-home message for a
you
patient. Just take-home message. If you
yes,
don't feel
please.
like your body is listening, or sorry, let's rephrase that. Okay, my take-home message is if you feel like something's wrong with your body, something's not right. You can't really put a finger on it, but you don't feel like yourself. You're going to all those doctors, you're explaining your symptoms. No one's really getting what you're trying to say. Don't
Mhm.
give up. Keep doing your research. Listen to your gut because you know yourself more than any of us do. Any doctor you see is not going to get to know you as well as you know yourself. So listen to your body, and if something doesn't feel right, it's probably not right. If you're doing IVF and you're not getting pregnant, and in your head you're thinking, well, what is it? Why am I not getting pregnant? And you're not getting a really uh, reasonable explanation from your fertility doctors, then it's okay to do your own research and it's okay to get a second opinion. But don't give up on yourself and don't second doubt yourself. It's not in your head. If you're having pain, you're not imagining the pain. If you're feeling tired and lousy and just not you, it's not in your head. There's something
Mhm.
making you feel that way. So my take-home message to all listeners, all women out there, is listen to yourself and believe in yourself. Don't let us doctors tell you what's normal and what's not. If you say I don't feel normal and your ultrasound comes back normal, it doesn't mean that everything is okay. There's probably
Mhm.
something going on. We just
Right.
haven't found out what it is. And
Yes.
and you know, maybe that's a good time to also say that endometriosis with imaging doesn't always show up. So lots of women
Mhm.
have normal ultrasounds and they still have endometriosis and they get told, "Oh no, you're fine because your ultrasound came back normal. You can't have endo. Your MRI was all clean."
Right.
That's not true. You can still have endo and have normal imaging. So, normal imaging does not exclude endometriosis. So, don't give up on yourself. If you feel like something's not right, if you bring up endo and your doctor doesn't know what you're talking about, then find someone else who's willing to listen.
Mhm. Thank you. I love your take-home message. I think it's perfect because I think patients have their own inner intuition and knowing about themselves, and they know their body's best. And so if there's something that's telling you in your gut that this is not right or this is not like I can't believe that nothing comes up on tests and
Yes.
imaging and my doctors say it's in my head. Like they're I absolutely agree with you that they have to go elsewhere or they have to keep researching and continue their journey and trust their gut for sure. Dr. Behbehani, thank you so much for being on my podcast and taking the time out of your busy schedule. And I know how many patients you help out there and how many surgeries that you probably have lined up throughout your week. And so I am really grateful that you were able to spend this time with me.
Thank you for having me on your podcast, Dr. Yang. I appreciate it and keep up the good work.
Oh, thank you so much. And I'm looking forward to continuing to co-treat with you in 2026.
Thank you.
So thank you.